Welcome everyone. Good morning. I'm coming to you from Beverly Hills, California. It's the morning here. It's 7 o'clock in the morning. I don't know what time it is for all of you, but welcome to this CyberSight webinar. Today we're talking about using simulation models to conquer the CCC. So here's my financial disclosure. I did create a company all around ophthalmic simulation models. We call it Simuli. And one of the models that we use is Rhexis, and that's what we'll be showing in a lot of the videos. There's more information on that later. So my background, I'm a general ophthalmologist in Beverly Hills, California since 2001. My focus is on cataract and refractive surgery. And this all came about, this whole simulation and developing teaching methods came about because after my after my residency in Georgetown, I had the opportunity to do a one-year LASIK-only fellowship with Dr. Howard Gimbel up in Calgary, Canada. It was an amazing experience. I learned a lot about LASIK at that time, but I did not get to do any cataract surgery or any intraocular surgery because I was a US citizen, and being in Canada, they would not allow me to do any cataracts. So I got to watch Dr. Gimbel and learn from him, but I couldn't perform surgery. And so my skills as a cataract surgeon were only at resident level. And then imagine taking a year off. And then I went back into practice. I started in a practice in Beverly Hills, and it's a challenging place to be. Expectations are very high there. And my surgical volume was low initially. And it was really a challenge getting back into intraocular surgery. In particular, I struggled with capsulotomy. And I remember those days, and it was not fun. And so I had to develop ways to practice techniques so I could rapidly improve my surgical skills. In fact, one of my good friends at the time showed me some plastic film that we got at the Hallmark store, and that's a gift shop, and we used that to kind of tear capsules, and it worked pretty well, and I refined that by putting things behind it and making it better and more realistic. And fast forward to today, we have this whole line of ophthalmic surgical training models called Simuli, and it helps other surgeons flatten the learning curve because I found that if it helps me, I want to be able to help other people. And then that just turned into a whole business, and that's a whole nother story that we'll go into a little bit. So let's jump into a polling question here. My understanding of CCC creation and management is number 1, excellent. Number 2, just okay. Or number 3, what's a CCC? So if you take a moment and enter your response, I'd just like to get a sense of who the audience is here. I'm guessing these are mostly surgeons in training at the beginning of their learning curve, going through things, is hopefully who we have a lot that's tuned in today. And I hope that this will bring up some valuable insights. So excellent is 6% on understanding of CCC creation and management. Well, that's fantastic. And just okay, we're hitting 81%. And what's the CCC? 13%. So it sounds like we've got the right audience here. So we're targeting newer surgeons, I should say, or people that are starting the CCC. So what is CCC? Let's talk about the background. CCC stands for continuous curvilinear capsulorhexis, with the most important word being continuous. The rhexis is the Greek suffix to tear, so it's a continuous curvilinear tear in the anterior capsule. And we'll go into why that's so important. But this came about over many years through contributions from Dr. Thomas Neuhan in Germany and Dr. Kamiya Shimizu out of Japan. But it's largely attributed to Dr. Howard Gimbel, who I did my fellowship with, and he's based up in Calgary, Canada. He's an amazing teacher and contributor to our field. And he presented the continuous tear capsulotomy in April of 1985 at the American Intraocular Implant Society Film Festival in Boston. I would encourage you to look on YouTube and other sources and read about the history of how he developed this technique, and go and see his old chalkboard explanations, which are just fantastic, how he explains the forces and why the capsule tears in the direction it does. And we're going to try to show that through our simulation videos as well in a little bit different format. So there are key steps to prepare for the CCC. Obviously, you have to understand the anatomy of the anterior chamber, the lens capsule, and the zonules, because those are all interacting together when we're doing the capsulotomy. You have to be able to achieve optimal visualization of the capsule. Understand that a lot of scopes have red reflexes, a red reflex lighting system that enhances the red reflex. Or if you can't get a good red reflex for whatever reason, you need to be able to use a capsule stain like trypan blue. You have to be able to see what you're doing in order to understand what's going on and control that capsulotomy. You need to have familiarity with the cystotome and various capsulotomy forceps, and understand that viscoelastic in the operating room is your best friend. It's a powerful tool you can use to your advantage. You have to know where to grasp the capsule and the optimal clock hours to start, stop, and re-grasp on the capsule. You have to know how to tear the capsule with control and understand the difference between a shearing force and a tearing or ripping forces, and we'll show that with a small demonstration. You have to have contingency plans for various complicated scenarios like the rescue technique, or if you have a small rhexis, or if there's posterior pressure and the rhexis is trying to run out. So you have to be able to understand how to manage those, and you can practice those with different scenarios. And how do you practice? Well, you don't want to practice on your patients. It's true that as we operate, we get greater proficiency, and that's really how you become a master surgeon over years of doing cases and learning from your mistakes. But you can practice a lot with models now prior to your initial cases, so you should feel confident and prepared going into them. So with CCC Creation, you're not going to learn it all here on a webinar. Of course, you have to go to many sources, go to your mentors that are teaching you surgery, go to lectures, go to meetings, and check out many videos. There are surgical videos by experts online that you can find on YouTube and iTunes. And I think a fantastic source is cataractcoach.com. I would encourage you all to go there. That's with Dr. Uday Devgan, who's a fantastic teacher and has contributed a lot through that website. There are multiple surgical scenarios to practice, and we should practice using simulation. There's no reason not to practice ahead of your cases. So just a little bit about my evolution as a surgeon and trainer and inventor, and really an entrepreneur in this is, we all go through this evolution as a surgeon from beginning to more advanced to mastery of techniques. But in that process, because I struggled and because I created teaching tools for myself, I shared those with others and try to help others as well, and found that it really kind of took off. And so I became an inventor just by default, and then as there was more of a need for those inventions, I became an entrepreneur and developed a whole business around it. So CCC was the first of the Simuli line of ophthalmic surgical training models, and that's what's led into this whole other line of being able to help surgeons on different things. We did a talk on MIGS earlier in the year, where we showed simulation with models using MIGS. And I think that's had a tremendous benefit in the field of getting people, even experienced surgeons, getting them to do their first cases on models. So we've refined these models over many years of hands-on experience working with residents. And the models are great because they're easily accessible, they're portable, they're lightweight. You can use them in the OR with your own instruments. And it's never going to be exact human tissue, but it accurately mimics the feel and action of the human capsule for our CCC. And other models, the goal is really to provide a platform where you can get experience, you can understand angles, you can understand where you're supposed to approach and how you're supposed to do things without being in the actual OR with your patients. So the thing that we're going to be talking about today is the CCC kit. That's what we'll be showing the videos on. Really, it's supplied as a kit. There's available refills, so you can just keep going over and over and practice multiple times. You can create multiple attempts at making the CCC, and you have the ability to increase the level of difficulty. So you can practice simple things like making incisions. You can practice the full rhexis. And you can practice more difficult scenarios, creating posterior pressure, shallowing the anterior chamber, rescuing the capsule if it's starting to run out and get away from you. Here are some early prototypes, and I think you can see my cursor. These little guys here on the side, I had a big revelation of using a suction cup for the bottom to help support the eye and allow eye movements. And that came from just seeing one of my son's toys that he was playing with when he was really little. I thought, well, gosh, why not use a suction cup on the bottom of a model eye? And that gives us stability, but it also gives us rotation and eye movements. And so I literally went across the street from my office in the drugstore, and I got some of these little candies from the little game toy things from the vending machine for 50 cents. And I opened them up and I cut them up and I made caps and I put the films over them. So this was my platform to work on. And on the left here is another version of that where I use a Dremel to kind of cut parts and make it. So this was part of the invention process. And then that turned into a more robust model here that we used for TrueVision 3D as they were showing their 3D technology at the shows. And we got fantastic feedback on this. It worked well for a number of years to help people practice in 3D without looking through the microscope. And people kept commenting, well, where did you get this eye? Where did this come from? And so we knew we were kind of onto something, there was a need. And so we decided to make more of a platform, more of an actual eye. And on the left here is some earlier prototypes. This is when 3D printing was not nearly as robust as it is now, but we could kind of test before we created models and cut metal and started doing injection molding. And then we made these molded parts that you see on the right, and it allowed me to, once I had a platform, we could create so many other different types of eyes for different things. And that's how this whole process developed. And you know, it's fast forward, I've basically become an expert in stimulation for ophthalmic surgery. I never set out to do that, but that's where we are now, and I'm really pleased that it's having an impact on the ophthalmic community for training. This, you can see some of the models in action. This on the left here, this was one of the core programs that was sponsored by Alcon for many years. It's been renamed, but basically they would bring residents in 2 or 3 times a year all across the country, and I would go there and help to teach. And in the process of teaching, we would use the models and we would get feedback and refine models. And each year we got better and better. And you know, feedback was fantastic, but there was always ways to improve until finally we have a much more developed product. And so it comes in a kit, there's refillable films. But basically I just wanted you to see what it is that we're going to be showing the videos on, that it is just a model that is very small and portable. And if you want more information, you can go to our website. There's a video showing how to set up the model and the features and things like that, but we're not going to get into all that here today. So why the need for simulation? Well, CCC is arguably the most difficult step in cataract surgery. For beginning surgeons, including myself, you know, when you're there and you've got to create that CCC and get it completed, your heart rate's up and you know that it's an important step. And you know, why is it important? Well, it's vital to the safety of the procedure during the surgery, intraoperatively, and also the long-term stability of the lens implant in the eye. And it happens early in the procedure. It's one of the very early steps that we do. So complications with the CCC can cascade and lead into a significant downhill effect where you get intraoperative challenges, vitreous loss, you know, inability to place the intraocular lens where you want to. All these complications that can affect patient safety and visual outcomes. So it's really important to nail the capsulotomy, and that really just sets the stage for a great case. The CCC is more important than ever now because of the ATIOLs, those are the advanced technology intraocular lenses. So these really require perfect and precise capsulotomies. I'm talking about lenses like toric lenses, multifocal lenses. There are multiple different types of those, the EDOF, the extended depth of field lenses, and even accommodating, pseudo-accommodating, and the newer accommodating lenses that are coming out. These really require an intact capsule, a good, precise, central place capsulotomy of appropriate size, 5.5 millimeters. It's so important that FLACS, or femto laser-assisted cataract surgery, is being adopted in a lot of places. You know, these big, expensive lasers, and CCC is a major component of this expensive technology, but surgeons, including myself, are adopting them because it's like cheating, basically. You know, you buzz the capsule with the laser, and you've just got this great capsulotomy ready to go. You pull off the anterior capsule, the lens is already chopped into, you know, quadrants or sextants, and you just take them out, and it's really like cheating. But you have to have your skills down. You're not, even if you have access to a femto laser for cataract, you have to have your skills down. There are going to be times when you can't use those lasers, pupils too small, or many of us are just not going to ever have access to those. Or in beginnings, I was a very early adopter of FLACS, and it was actually more challenging doing surgery with the laser because we'd have tags and things where it could, you know, you pull on the capsule wrong and you'd have a weak spot and it would run out. That's largely been resolved, but as an early adopter, we had to know how to manage those issues. So in practicing CCC with simulation models, you can practice all the different steps. You can practice entering and exiting the incision and filling the eye with viscoelastic. You can practice moving smoothly within the incision. We're going to talk about oar-lock versus pushing on the incision. You want to practice not distorting the incision because you don't want to lose viscoelastic. You can practice initiating the flap and then completing the CCC and doing that with a cystotome or forceps. And you want to practice the rescue technique and other challenging scenarios. And we're going to show video clips. We're going to break it down and show video clips as we go along here. So we'll get into those pretty quickly. Let's jump into another polling question. Before my first cataract surgery, I practiced with models, I practiced on animal eyes, I practiced with human cadavers, or number 4, I did not practice on anything prior to my first cases. I'll tell you my own experience. We had a few wet labs. This was back from my residency, was 97 to 2000. And we had a few wet labs where different companies came in and brought some pig eyes in for us. And we tried to do capsulotomies. We sit there and struggled with the capsule because it was very rubbery. The view was very difficult. And then you get the phaco probe in the eye and the cataract is very soft. And I really didn't feel like I got much out of it. If anything, I maybe got some bad habits on the capsule out of it. And so, we just didn't have electronic stimulation like they have now with the IC system. And they certainly didn't have the models that we have created available back then. So let's see the results here. So before my first cataract surgery, I practiced with models. That's great, 16%. I practiced on animal eyes, 56%. That's very common. I practiced with human cadaver eyes, 0%, or I did not practice on anything in my first case is 28%. So it's interesting. A lot of people practice on animal eyes, and I think that's kind of been a standard of care, like with pig eyes, especially. But patients, and honestly, they're just kind of gross, and they're just not realistic. Human cadaver eyes. I practiced on those like with some of the early MIGS cases because that's what Glaukos brought in, and that was just not the best experience. I think in this day and age, it's not acceptable to not practice on anything. Another option we didn't put up here is you could get grapes or you can get tomatoes, and you can practice doing capsulotomies on that, and that will actually work. It's better than nothing. But with models now becoming more and more available, if you don't have access to them yourself, go to your institutions, wherever you're training, and encourage them to say, hey, let's reach out, let's get some models in here, let's build up a better training program for ourselves. So again, the practice options, human cadaver, animal eyes, there are many limitations, including cost, availability, sterility, safety, ability to use in the OR, and they're just not pleasant. The preserved human tissue, it really is not that realistic. Once it's preserved, you're really not getting the benefit that you think you are. And that pig eye anterior capsules we talked about, it's very rubbery, and it's actually going to create bad habits. You're not going to understand the proper tearing forces if you're doing capsulotomies on pig eyes. So the model eyes really start to make sense. You can do them, even outside of the OR with a magnifying lamp. But it's best in your OR with your scope and your chair and your instruments, and you can do it multiple times, and you can create various scenarios. So the advantages of stimulation with models is, like I said, you practice in your own OR with your own chair and your own instruments. So that's an advantage we have over some of the digital systems where the instruments I find are not that realistic, and you're not getting yourself depth of field and focus and hand positioning as you would in the actual OR. So with the models, you can practice the body and hand positioning, you can optimize your approach angles. You're working on your actual scope, so you're going to learn how to focus, how to zoom your scope, learn that you can adjust your lighting. Now on the models, you're not going to get an actual red reflex, but you can play with your scope and say, okay, well, here's my red reflex button, here brings in that third light, and that's going to enhance my red reflex. You can certainly work on your stereo vision, engaging depth within the eye, practicing multiple scenarios, creating that muscle memory by doing things over and over and over again in an environment where there are no penalties for mistakes and there's simply no stress. So I believe that simulation models are becoming the gold standard in training. And especially for CCC, it's extremely helpful for surgeons before their actual first surgery. This has been validated by feedback that I've gotten from many years working with experienced and novice surgeons, that these models provide a training platform to practice in this non-stressful setting so you can make adjustments and gain confidence. Again, there's no penalties for mistakes. You try out different techniques. This repetition allows for muscle memory, which is so important, and you gain that experience and confidence so that you can do a better job for your patients. So we're going to jump into the videos here now. You can obviously see there's the model that we showed before. We can make incisions with these. It's not really an incision trainer, but you can certainly practice the correct angles with your keratome. This is a 2.3 or actually maybe a 3 millimeter keratome here. And we're just going to show you that, line it up, get the angle nice and flat, smooth, dimple down, and create that single or biplane incision. And you can do that multiple places around the eye. The eye is not going to collapse. You can do that over and over again. We can fill the eye with viscoelastic. So here's what, as a right-handed surgeon, I would fill the eye with the left hand through the left-hand paracentesis. But I can also practice filling it through the main incision, just getting comfortable working in that incision, not hitting the iris, not hitting the capsule. On another attempt, I might go from the right-hand paracentesis. You're going to create these paracentesis. You're going to practice making those incisions and filling the eyes using different hands, coming at different angles. And look, we haven't even touched the eye yet. We haven't used it. We can just keep going in and out and doing these things. Same thing, we're going to practice entering and exiting the main incision. So here you'll see the cystotome coming in. We rotate as we go through the incision to not affect the cornea, the endothelium. Make sure that we're careful not to hit the iris or the capsule. Let's see that again. So we're rotating, and then we get in centrally where the light reflexes, back to center, rotate back down, and we'd be ready to initiate our capsulotomy. You can do that multiple times. We haven't even broken the capsule. There's nothing to reset. Just do it over and over again. Here's entering with the forceps. Same thing. We're going to enter, rotate to the side, and then rotate and turn. And that can be done over and over again without even initiating a tear yet. So let's talk about oar-lock pivoting versus pushing or distorting. It's really, really, really important to pivot in the incision, like an oar-lock like an oar in a lock that rotates in that position. So where's the pivot point? It's at the incision. You don't want to push on the incision. You want to be able to slide in and out and pivot so that you're not distorting the incision. If you push on that incision, you're going to move the eye away from you, and you're also going to cause loss of viscoelastic, which is going to shallow the chamber, and it's going to dome the anterior capsule, and now your capsule is going to want to run downhill and out of control. So, with the eye movement, what you'll think is, gosh, why is that patient looking around? They've been so good, and now all of a sudden they're looking around right when I need them to hold still, and I'm trying to go over here and do something and grab the capsule. Now the patient's moving. Well, they're not moving. You're moving their eye. You're pushing on the incision. You're lifting up, or you're pushing to the side. So let's watch that here. So here we are in the incision. Notice when the tips go to the right, the back of the incision, the back of the instrument goes to the left. We're sliding in and out. There's no distortion. We can move all around. We can attack any area, any clock hour in the eye. Now, if we don't pivot, we hit the side. Obviously, we're exaggerating here, but if you hit the side, you're going to move the eye. Back to pivoting, and you can see minimal eye movements, and there's no loss of viscoelastic. But if we push down on the incision, see the bubbles go out, pushing down, and distorting, or if we lift up, we're going to distort. There comes some air bubbles, so that's pushing down. So you got to stay sliding in and out, stay on multiple planes, stay in one position. And we can practice movements inside the eye without even creating a CCC. So here we are, we haven't pierced the capsule, we're just pretending. We're grabbing at the clock hours. This is after we've done some, we know where our attack is. Go back and just practice. Tips to the right, back to the left, grab where you think, 2 o'clock maybe. Come around and just keep practicing those muscle memory maneuvers until you get it down. So let's talk about initiating the tear with the cystotome. First of all, you have to understand what the cystotome is. It's usually a 27 gauge needle, and it's pre-bent when it's a cystotome, but you can bend your own needle. You can take a 27 gauge needle, you can bend the tip so the needle is pointing downward, and then you put another bend in it further so you make it easy to get in and out of the eye. So the bevel of the needle is 2 millimeters, and that's important because you can use that as an internal ruler. Sometimes you've got a widely dilated pupil, and it's hard to gauge, well, I want to shoot for 5 or 5.5 millimeters. Well, you've got an internal ruler there if you understand that that bevel is 2 millimeters from the tip to the very back of the bevel. And you also have to understand that the tip of the cystotome, there's the point, but then there's the edge of the needle, and that edge is what cuts. That's the cutting edge. And if you move that edge laterally, you're going to create a precise, predictable cut in the capsule. If you just pierce the capsule and pull down, straight down, you're going to create an opening that's a little bit unpredictable. So you want to pierce and go laterally with the cystotome, either way, wherever you're comfortable. I think most people would go to the left if you're a right-handed surgeon and then bring it down. But as you pull down, that's what's going to create the flap. So you can, let's watch this in a minute. So here's the cystotome on the left, and I have my capsulotomy forceps on the right. And what you'll notice about the forceps is that we have hash marks on them. So that's a very helpful tool that we'll use, we'll talk about later about measuring. But the point is that the capsulotomy forceps is, you can see from the tip to the second hash mark, that's 2 millimeters. I've lined the second hash mark up with the tip of the rhexis of the cystotome, and you can see that that is 2 millimeters of the bevel. So let's watch the video here. It's just showing, there's in better focus now. That's the cystotome needle. There's the side. That's the cutting edge right along there. That's what we want to use to cut the capsule predictably. So here we are. We're going to initiate the tear with the cystotome. We're right in the center. The light reflex is there. We're going to poke in, and now we're going to drag directly horizontally. And look at that nice, precise tear. It's cutting the capsule. And then we start to pull back down towards the incision, and that's what's going to lift the flap. So let's watch that one more time. Pierce in, go exactly horizontally, nice tear, and then when you get to where you want to, pull down. And again, we can use that bevel as a 2 millimeter indicator inside the eye. So here's another version. We're going to go a little bit more on a curve. This was kind of creating the flap a little bit more of a tongue. So it's up and over, but still using the cutting side of the cystotome. And here it is again, another example. Pierced in, arcing over, and then pulling down. And it's that pulling down that's going to start to lift the tongue of the capsule up. And look at how nicely positioned that is, where we can go in and just grab that with the forceps and continue on our way. So one last initiation and tear. And pulling down, there we go. Ready to go around. So you can do the CCC only with the cystotome. It's an older technique, but it's safe if there's patient movement. So we're going to show a little bit of that. We've initiated, we've pulled down here, and we're just going to stay with the cystotome. We've got the capsule folded over on itself. There's the double capsule now, and we're just walking it around very safely. If the patient were to move, we're not holding the capsule, and everything continues great there. You need to be able to use various forceps. Try them all. Find what works best for you. I like ones that have measurement marks on them, and once you get your system down, you're going to use the same tool every time. You're going to measure and then initiate. Probably you'll initiate with your forceps, and eventually you won't even have a need for the cystotome. So this is using forceps. We're going to start here, initiating with the forceps, and then we leave a nice flap there, grab it, pull down. Now we're on the 6 o'clock position. Leave the capsule in an optimal place, re-grasp it, tips are out to the side, following around, and that's using the forceps. There's fantastic control. We can reposition the capsule when we need to, and then continue on. There we go. Look at how we're leaving the capsule and then continuing on. So the capsulotomy forceps that I use have measurement marks. So I can, if I have a widely dilated pupil or a small pupil, I can see where do I need to be. I can use my measurement marks. It might be hard to see, but there are 6 hash marks on there. And you know, I like to aim for 5 to 5.5 millimeters. So this is showing the measurement marks. We've already initiated, and now we're going to see where we're going. So we use the measurement marks. You can stop at any point and use those measurement marks. There we are. Let's see another one. So here we're going to initiate. Now we're going to go a different way. We're going to bring it up and around, just trying a different technique. Maybe we like that better. This is not how I choose to do it, but some people like this. You can see it does leave the capsule in a nice position to come in there and grab it very easily, get the forceps on either side of the capsule, and you know, you start your capsulotomy. And oh, let's stop and measure. Let's see where we're going to be aiming for as we come around. Are we big enough? Do we need to extend as we continue along? You can certainly even initiate with forceps. These forceps are designed to be able to initiate the capsulotomy. So we're going to pull straight down to 6 o'clock, grab, and away we go. It's just more efficient. You've saved a step. There's no need for the cystotome. But practice it on these models and get comfortable with it. I don't think you want to practice a different maneuver the first time with your patient. You need to know where to grasp. I call it getting a grasp. You have to learn where to grasp the flap for control, safety, and efficiency. And it's all based on the point of propagation. If you're too close to that point, it's less safe because small movements are going to cause unwanted tearing. If you're too far away, you have less control and it's less efficient. So you want to grasp appropriately so you can probably get around your capsule in maybe 3 grabs. It doesn't matter. You could grab it 10 times. Nobody cares. But as you become a more advanced surgeon, you're going to become more skilled and you want to become efficient. I think the best clock hour locations to grasp if you're a right-handed surgeon and if you're initiating to the left and going counterclockwise, I think you want to re-grasp at 6 o'clock, 2 o'clock, and 10 o'clock. And you just with those 3 grasping areas, you're going to get around. And those are great clock hours because of the approach angles. And you can leave the capsule in an easy position to re-grasp it. So let's see that here. So we're up around the 2 o'clock. We position the capsule, folded it over, positioning it nicely. We want to grasp. Didn't like something there, came out, maybe put in some viscoelastic. That's too far. That's too close. Right about there. Then we can re-grasp and fold it over and get it on tension and come around. So not too close, not too far, just, you know, an optimal position. You have to know where the tear is going. Once you get the capsule folded over onto itself, it shows you the exact curvature that will be torn. And the tips of the forceps should trace the outline of where the tear will go. That's super important. I'm going to show you that on the video. And with a small pupil, you can even tear the capsule outside the pupil border. You won't be able to see the propagation point, but you know you're under control because of what you're doing. So here, this is going to show folding the capsule over. And once that capsule's folded over, the tear just follows exactly along behind it. So I'm going to try to show you that again here. So here, look, 2 important things. Follow the tips. Look at where the tips of the forceps are. The tips are tracing where I want that capsule to open. So see how the tips stay open? Too many people go inward too much. You want to stay out, follow the tips. Look at where they are. They're tracing exactly the path of the opening. And also, as the capsule's folded over, you can see right here, let me stop it. As the capsule's folded over, you can see exactly that this curvature mimics this curvature, and that's where it's going to continue to open. So those 2 things, when you get the capsule folded over and following your tracing the tear with your tips is really the key here. The other important thing is tension off versus tension on. Tension off to manipulate the flap. So if you're holding the capsule with your forceps tips, you bring the tips down towards the point of propagation, and that takes the tension off. You can safely manipulate the flap. Tension on is when you're ready to propagate the tear. So let's see that. So here we go. We're going to initiate the capsule opening with the cystotome, bring it down. The cystotome works best on these models. It's a little bit harder to initiate with certain capsulotomy forceps. So that's why most of these videos you'll see us initiate with the cystotome. Okay, so we're going to stop here and re-grasp. And what you'll see is as we bring the tips down towards the point of propagation, now we're tension on, now we're ready to run. We're pulling it around. The tips are tracing where we want to go. The capsule's unfolding, we're keeping it down. We're not pulling up on the capsule, we're keeping it down on the plane. Now we're going to reposition. We're around that 2 o'clock position. It's easy to re-grasp, not too close, right about there. Tips down towards the point of propagation. And now I have movement. I can move that capsule without tearing anything. And here we go around a little bit more. We're tension on now. We're opening the capsule. The tips are staying out. We're tracing the point. The capsule's folded over. We got to our 10 o'clock position. Reposition the capsule. Get it in a nice position to grasp. And I'm going to grasp a little bit too far back, but just for demonstration, we're going to bring those tips right down towards the point of propagation. Look how much I can maneuver that capsule and nothing is happening. There's no tear. Now we're going to go tension on. It's like a train, right? Train cars that are coupled. You put the tension on and then things are going to move. And because I grasp so far away, we start to run out of room. And there we go. We have to drive those forceps tips up the other direction. So that's a huge lesson there. Let me just see if I can show you in slow motion here and back and forth. So let me get to right here. So here we are. So tension off. This is tension off. Look at all that manipulation because the forceps tips are near the point of propagation. But once we go tension on, we fold it over. Right there, tension is on. And now any further movement is going to create propagation of the tear, like that. Remember, viscoelastic is your friend. You're going to fill the anterior chamber with visco to create space. Can you imagine what life was like before viscoelastic? with such a tremendous benefit we have. We can flatten the anterior capsule, we can clear the view, we can manipulate the flap. Viscoelastic is certainly your friend. So here's a case where we had too small of a rhexis. We're reinitiated with the scissors. Now we're grasping it. Look, I've gotten down into the cortex. I've fluffed it up. It's hard to see. Take a second, put some viscoelastic in, clear your view, and then continue on around. And make sure you can always see. It's a little bit hard to see right there. I can't see the point of propagation. More visco, clear up that view, re-grasp, and continue on doing your work. So viscoelastic is cheap. It's a lot less expensive than vitreous loss, right? Shearing versus tearing. What do we mean by this? So there are different types of forces, and they act differently. I'm just going to show you with a piece of paper here. This is a shearing force, and that's what we're typically doing when we're tearing the capsule. But when sometimes we pull the capsule differently, in a different fashion, this way, and you can see if that's a different type of force. That's a tearing or ripping force. And look at how I can control the tear differently. So I can shear, and I can drive it where I want it to go this way, or I can tear and rip. And that's super important as we get into these next slides in talking about the little rescue technique. The little capsulorhexis tear-out rescue is attributed to Brian Little, and this was published in the Journal of Cataract and Refractive Surgery. And I would encourage you all to go look this up. It's easily available online. It's a PDF. And these are three of the most important pages you will wish you had read when the capsule starts to tear outward. I learned this technique by reading his article and watching a video, and it was later that week I had to use it. And I was so glad that I'd read this. So the keys to this are you have to recognize early running out of stop. The further out it goes, the harder it is to fix things. You want to fill the AC completely with viscoelastic. Remember, it's your friend. And then you have to understand that the force applied to the capsule is then reversed in direction but maintained in the plane of the anterior capsule. That's taken directly from Dr. Little's article. Now, what does that mean? It means we're going to pull in the opposite direction, but we're not lifting up on the capsule. We're staying in the same plane of the anterior capsule. If you need to, make another paracentesis for optimal angle of approach. Unfold the capsule using viscoelastic or forceps. Don't use a cystotome. You might cause further tearing. And you're going to apply traction in that horizontal plane of the capsule, initially circumferentially backwards. So it's exactly the opposite direction that you would normally be going. And then more centrally, as you come more radially, that's going to initiate the tear. It's going to be that ripping or tearing force. And the tear will propagate toward the center of the capsule. Once the tear is rescued, the capsule flap can be folded back over, and the CCC continued as normal. So let's watch this here. This is cataractcoach.com. This is Dr. Uday Devgan, a fabulous teacher, and let's watch his video and explanation.
Cataractcoach.com. Look at this rhexis. It's running out. We can grab it, pull back towards the forceps in this direction, and rescue it. And we can bring it back in and make the rhexis normal again. That's a neat technique. And thank you, Brian Little, the person who described this technique. Watch in slow motion. We have a run-out capsulorhexis and a small eye, shallow AC. We grab the capsule here, the part that's flipped over, and now we pull backwards towards our incision. Pull towards the instrument, the forceps. That will allow this tear to come back inward. So right now we're right at the pupil margin. It could go towards the zonals, but if we pull inwards, watch carefully, it'll tear towards the center of the eye. This little technique is very useful, and all surgeons should certainly know how to do it. Now, once it's a normal position, now flip back over and continue the rhexis normally. The slow motion video really tells the story. If you need to, go back in the video and watch it again.
So we just saw Dr. Devgan's great video, and hopefully you also saw things like tension on versus off, manipulating the flap. What you didn't see is putting the viscoelastic, and remember that's a critically important step. But let's compare now that, that presentation with what we can do on the models and how similar it is and how valuable it can be to practice with this. So here's our little rescue technique. You can see the tips are going outward a little bit. The capsule's starting to run. Recognize it early. Okay, so here we are back with a little rescue technique. Notice that the tear is running out. We're gonna recognize it early. We're gonna fold the capsule back over. This would be a great time to put viscoelastic in. We're going to get that capsule in position so that we can do the tear. So now we're gonna pull back. See, there's no tension on the capsule. We can move all the way around. We have control. There's the move, pulling back circumferentially, and then as you come radially, you start to see the rescue. It doesn't have to be a big, aggressive maneuver. It's not fast. It just has to be effective enough to accomplish what you want. So it's that filling with visco, then unfolding the capsule, pulling back circumferentially, and then pulling more radially. As you pull radially, that's what creates the rescue tear. Let's watch another example here. And I'm glad to see that, we're still continuing on here. So here we're opening up the capsule, and maybe we've got, a small tear here. We're gonna open up the capsule. Let's grab with forceps and watch the tips of the forceps. They're going around. And maybe there's some loss of viscoelastic, maybe there's some posterior pressure. Things seem to be going okay so far. We're gonna regrasp, we're gonna reposition the capsule, and then look at where those tips are going. That was wrong, right? We didn't trace the outline. The tips went out, and it caused it to intentionally run out there. Watch that again. Watch the tips of the forceps. They should be going here. Look where they went. So look where the tear went. So stop, pull it back, pull circumferentially, and then as you pull radially, that's what creates the tear. So we're gonna go in here and grab. Now you'll see it tear a little bit, but no big deal. We can just grab again, and it's that radial maneuver after your circumferential that creates it, and then flip back over. Here's another rescue coming up. And oh, that's a really tough angle, isn't it? That's a very difficult angle. So you might have to make another paracentesis or go in through a different side port, come in with a different forceps that can go through a small paracentesis, and now we can grab it at the proper angle, and we can grab the capsule and continue on more easily. And one last time, finish it off. Let's look at this again, and here's another example. Again, we're going to initiate with the cystotome. Actually, no, this time it's with the forceps. So we're going to initiate with the forceps at 6 o'clock and bring this around. Everything looks like it's going great. We're getting a nice capsulotomy. Regrasp, and then, oh, what's going on? Tips went wrong. Now you have to rescue it. Pull back and then radially. That's the maneuver. Let's look at that again. Let's stop here. So when we say pull circumferentially back the other way, normally you're pulling this way. So circumferentially back is this angle. You put the tension on, and then as you pull it radially, that's what creates that ripping, tearing maneuver. Watch it here. Bam, there's the rescue. Fold it over with no tension and continue on. Oops, I didn't mean to advance that. So let's go one more time on that same one here. So I'm gonna jump ahead. So here we are. We've rescued it, nice rescue. Let's watch the rest of this video and see what happens. So now we're going to continue along, right? Tension's off, now tension's on, continuing around, struggling a little bit. Oh, what just happened there? My goodness. So let's back up and see what happened there. It's a subtle mistake, but watch what happens. So as we continue on the tear here, we're almost finished, but the finish line is right there. Well, what happened is there was lifting up of the capsule. So we pulled it up as opposed to keeping it folded over and moving it around circumferentially. We're lifting up on the capsule, and bam, it just caused a sudden radial maneuver. So you've got to stop, and now we got to fix that. So what are we going to do to fix that? Reposition the capsule. This would be a great time to reinflate with viscoelastic, deepen the chamber, flatten the curve, and we're going to come in from a different approach angle. And now once we grasp, it's almost like an immediate rescue maneuver. It's that immediate radial tear, bam, saves it and continues on. Fantastic save, and then optimize your approach for the final finish there. And there you go. Here's one last demonstration of the little rescue technique. And we're bringing it around. Regrasping, walking it out, and rescuing. There it is. Okay. So what if we have increased posterior pressure? We're going to show how you can simulate that on the model, because with increased posterior pressure, it's almost like you're doing a continuous rescue during the whole CCC procedure. What I mean by that is you're going to be pulling more radially at certain times as you're propagating the tear. So here we go. Everything's under control. We've initiated the capsule. We flipped it over. We've got great control. We're going to regrasp here. Tension off versus tension on. There's off. There's on. Tips are out. Everything's just going perfectly. What could possibly happen? Well, we're going to stop and we're going to make this more difficult. We're going to take the model. We're going to increase the posterior pressure by twisting it and dialing up the pressure behind the capsule. It's going to shallow the chamber and dome the capsule. And now it's going to want to run downhill. There's some viscoelastic to clear the bubble. Visco is our friend. And you're going to see now as we start to continue on in the normal fashion, it's just going to want to unzip and open up to the outside. So watch the tips at various times. We're going to pull more radially. There it is. See it opening up as I'm leading it. So we're going to try to rescue a little bit here. We're going to rescue and get it back under control. There's the radial maneuver. And watch, look at where I'm pulling. I'm pulling radially to propagate that tear. I'm not leading the tear. I'm not out in front of it. If I do, it starts to run. I have to pull radially to keep it under control. That's what I mean by it's like a continuous rescue maneuver, because you're actually pulling radially as you're letting the, it's not just for a moment to redirect it. When there's that increased pressure, you can keep it going around that way. Let's talk about the baby rhexis. It sounds cute, but it certainly is not. It creates intraoperative challenges like removal of the nucleus and cortex. It's going to put stress on the zonules. And post-operatively, it's going to create challenges like phimosis of the anterior capsule and really cause a problem with the advanced technology IOLs. So you want to be able to reinitiate it and make it larger. And if you can get through the case safely, you might want to consider waiting until the IOL has been implanted, because then there's obviously less risk. You're at the end of the case. So here we go. We're going to initiate again and maneuver around here. Get through this part quickly. Everything looks great, right? Well, not really. Look how small we are now. This might be intentional. Maybe this is a case of an intumescent white cataract, and we're going to do a double rhexis, a baby rhexis and then a bigger rhexis. But anyways, it's very common for beginning surgeons to end up with a baby rhexis, 4 millimeters or sometimes even smaller. We're so concerned about letting it run out that we stay small. We don't keep our forceps tips out where they need to be. And we end up with this baby rhexis. Oh, we think that we did a great job. We got our rhexis. It's continuous. It looks perfect. It's centered, but it's not. This is a real problem. So go back in with like a 27 gauge Van Ness scissors, microsurgical scissors, and re-grasp it, fold it over. Look at this control. Now the tips are out where we need them to be. Now we're going to reposition. We're going to re-grasp, tension on, continue around, pivoting in the incision, leaving the capsule where we want to. So all the things that you've learned, you're using to your advantage now. You're putting everything together, and viscoelastic, fill, clear the view, grasp it. The only thing we could have done better here is finish from outside to in. You'll see a little nub at the very end. Watch, right there. So if we'd gone a little bit wider at the end, you always want to finish from outside to in to incorporate all that other stuff in there. Only a couple more here. Let's say we've got a decentered rhexis. Well, now you can reinitiate just with your cystotome if you want. Get that flat flipped over. It's a good rhexis. It's a little bit small, but it's decentered. Let's fix it. Reinitiate, grab carefully with precision, bring those tips around, keep the tips out where you want them. I'm exaggerating this. This might be bigger than we would normally want, but this is practice, okay? And fold the capsule back, reposition, get comfortable, add visco, clear your view, get rid of the bubbles, flatten the anterior capsule. Now we're ready to go back in, grasp, tension's off, tension on, fold it over, carry it around, tips stay out, tracing exactly where you want it to go, and you're gonna have a beautiful rhexis there. And we're gonna finish it up, and this time we're gonna finish from out to in, and One last time. It doesn't matter how many times you regrafts. Look at that control that you can obtain. That's a great rhexis. You can have a great case with that. Here's another one where you can spiral outward. So in cases of a white intumescent cataract with increased posterior pressure, one technique is that you're going to start small and then spiral outward. So we're initiating with the cystotome, we're flipping it over, there's pressure, we're careful. We don't want to get that dreaded Argentinian flag sign. In this case, it would be different with the, when you have trypan blue stain on the capsule and then that capsule splits and you have the white in between the blue on either side, that's the Argentinian flag. So this is one technique. There are many. CataractCoach.com has some great teaching tips on that. But here we are. You can see that we're getting continuously bigger as we go. Immense control, capsule flipped over, tension on, and we're just going to get bigger and bigger as we go here. We're not going to let this capsule run, even though we've dialed up the pressure, and there's a lot of pressure behind this. And you can see we're just getting bigger and bigger, tracing the tips exactly where we want that capsule to go. Fold the flap over, get the tension back on, stay wide now as you want to come around bigger. And so if you use models to get to this level of control and stability and technique and understanding of tearing forces and where you need to be with your tips and where you need to be pulling and how you can rescue and maneuver things, imagine how comfortable you're going to be going into your cases. And this will translate over into all sorts of other intraocular maneuvers if you get your comfort level down with these types of maneuvers. So that's the last video to show. The main takeaway here is practice, practice, practice. There's really no excuse in this day and age not to practice. Here's showing the practice that I did just for making these videos. It's a simple setup. I'm in my own OR. Here's my phaco machine. Here's my microscope. I pulled over a side table. I grabbed some instruments, some Viscoelastic that we save some Visco sometimes at the end of cases. If I know I'm going to need to use some, we'll just use any Viscoelastic that maybe got open but didn't get used. It's going to get thrown away. We'll grab that. You can use other sources of gel. And look, here's 22 tears. They're not perfect, but they're perfect training, right? They're continuous, they're curvilinear, they're well centered, and I was using 3 different models here to keep things set up and moving along. It doesn't require a lot of setup or a lot of time. You spend an hour or 2 doing this, and you're going to gain a lot of ground. And do that a few times over the course of a month, and it's going to be amazing. And record yourself. We all record our surgical cases now, but record your practice attempts. You can learn from reviewing your recordings of even your practice attempts on models. Find your mistakes, analyze where it went wrong, and fix it. And remember, if you want to be like Ike, you can use simulation.
Take the pressure off.
That's right, to take the pressure off. Get rid of that pressure going into your cases. Here's a quick word from Dr. Gimbel, who I'm so indebted to. He's such a great teacher and mentor. Because of what I learned from him and because of that experience is what developed me into the surgeon that I am and the experience of developing the models. So I just want to play a quick word from him.
Hello, I'm Dr. Howard Gimbel. I'd like to speak to you about an important teaching aid to help master the technique of continuous curvilinear capsulorhexis. I'm pleased that the CCC technique has become integral to modern cataract surgery. The teaching model, developed by Dr. Stoll and his colleagues, is a simple yet effective method to help master this crucial step in cataract surgery. I would encourage all of you that desire greater proficiency in the OR to utilize this tool to become more confident and effective cataract surgeons.
So, my mentor, what an amazing doctor and person, Dr. Gimbel. Thank you for your endorsement of the work that we're doing. So special thanks to Dr. Howard Gimbel, my dear friend and colleague, Nicole Fram, who helped me do some of these videos that you watched of the tears and the different techniques. Also to Dr. Uday Devgan for letting us use his video from CataractCoach.com. And especially, of course, to Orbis and CyberSight for this opportunity to come to you guys. And again, I apologize for the technical difficulties. It happens sometime, but hopefully recovered. And thank you all for your time. You can find out more information about us on our website. I think we're going to take some questions now and see if there are some up there. So Is it safe to finish the last hour of capsulorhexis by Van Ness scissors? I suppose under certain circumstances, let's say you've got a fibrous capsule that you can't tear through safely, and what I would do first is try to come around the other way, or if you can go outside of it and incorporate that fibrous plaque into the capsulotomy. I mean, if that's what you have to do, that's what you have to do. You can use a Van Ness scissors and cut and reinitiate or cut through it if it's really that fibrous. So yes, it's not an ideal choice, but if that's what you need to do, that's what you do. Here's a question: does the product ship to South Africa? We're working with a distributor that can help us get things where they need to go, and hopefully we can partner with Orbis and get things out around the world. So because we really, the goal is to get people trained. How can we get Simuli in developing countries? Kind of same answer is we're working on that. Actually, it's I'm a really very small company. We have a big footprint now because we work with a lot of the big companies. So if you have access to some of the big surgical companies like Alcon, Bausch & Lomb, Johnson & Johnson, I work with all those companies. We can get kits to them and they can get them out to you. That's how we've gotten them around the US and around Europe. We'd love to get into the developing countries. So we are working on that. Any discounts available for government academic institutes or just volume discounts? I don't want to get too much into that stuff, but all that stuff is, just contact us. Is it available for international purchase? It is available for international purchase. What are the best capsulorhexis forceps to use as beginners? Boy, try them all. That's my best advice, is try them all. They're different ones. I really would encourage you to get something that has hash marks on them. And that way you can see, you can judge. I like the ones that I use are from MST, Microsurgical Technologies. I have no financial interest there. I just think they're a great company. They make great instruments, but there are many that are like that. Here's a question: for how long can a simulator be used? Well, there's really, ours doesn't have much of a shelf life problem. It can sit around for months. The polymer clay might start to dry out after about 3 or 6 months. But that's pretty easily attainable. You can get more, and you can put it on the shelf and revisit it, a month later, or after you've had some experience. You can come back to it and practice and say, I've been going clockwise all this time, but I see everybody else going counterclockwise, but I didn't want to try that on my patients. Well, try it on a simulation, try it on an electronic simulation, or try it on a tomato or a grape, or get a simuli. Try it a different way, and I think you're going to find that there's a reason that many people do it a certain way. And maybe that's not the best way for you, but you might find that it is, and it's best to try it outside of using it on your patients. So I think I got through most of those. What is the recommended number of films to order for practice? Well, the kit comes with 10 films, and you can get refill kits. Those come with 10 films, so it's whatever. But remember, you can do so much practice even before you puncture that capsule, getting your positioning, muscle memory. It's sliding in and out of the incision, not tearing the capsule, just doing all those other things. You can gain so much practice just from that. So the kit comes with 10, and you can go from there. More information on the website if you guys want more information there. I think that's all of the questions we have now. So thank you again all for your time. Sorry about the technical difficulties. I think we recovered okay though, and got through it. And good luck with all of your training. And just keep practicing, and you'll get there. All right. Have a great day, everyone.